The focus there is on a pathological basis for the cognitive change that we're seeing. And we'll talk a little bit about that. It's a very interesting way to look at it. Most people focus on the clinical, what we see behavioral-wise in people or within the actual examination, how people are performing, and how dissimilar that is to what would be expected for age or education of that individual. And so, when we, and what about you? What would you say about it?
Well,
Dementia?
at first I thought dementia was just forgetfulness. As you get older, you forget. You know, now I'm learning that it's so much more than that. I know, my husband is not there yet, but there are members of his family who have had it, and I have survived it, and so that's why I'm here now.
Okay.
To learn what I can.
And so you pointed out a couple of I'm glad you're here, first of all, and second of all, you pointed out some very good things there. That one is that you initially thought that dementia was forgetfulness and normal or slightly above normal forgetfulness. While memory is an essential component of many forms of dementia, it's not necessarily the component of all forms of dementia. There are actually many different types. And that's what I think we need to focus on at first. So dementia is quite simply, in its broadest sense, is a decline in cognitive status from a previous state. And when we talk about clinical dementia, what we're referring to is something that's significant enough to affect both work and or social life. So there are these people have had a change in some aspect of their cognition that allows them to not function in the capacity that they once did, either work and or socially. And there are many, many different types of dementia that are out there. Many of them, when we talk about dementia, they can be categorized by whether they're reversible or irreversible. What is the manifestation of the dementia that we see, the cognitive disturbance? Whether or not these things proceed fast or slow. Whether or not these things are associated with other behavioral abnormalities. And so what happens is that the individual is looked at in totality at a variety of symptoms to figure out what is the cause of dementia. And I've listed many of them here, certainly not all. But this is just to give some idea of, some of these were selected because they're associated or similar to an Alzheimer's type of dementia. And others are used to distinguish as being something very different than Alzheimer's disease. All of these slides will be given to you. Feel free you don't have to write anything down other than little notes that you may want to have. But what I've done here is I've broken them down. The first 5 things up there are categorized by the fact that oftentimes, not all, particularly in the case of stroke, but are things that are reversible forms of dementia. So things like thyroid deficiency, B12 deficiency, significant clinical depression, different types of infection, and in some cases different types of strokes can cause a demented state that is then reversed. Okay, and so oftentimes whenever we're talking about thyroid or B12 deficiencies, and even depression, these are things that can be pharmacologically managed to have a reversal, if you will. The other thing that can oftentimes be associated with dementia and is sometimes confused to be Alzheimer's disease is post-anesthetic events, so post-surgical procedures in the elderly is one that is very common, and traumatic brain injury, particularly whenever people lose consciousness, can cause a demented state. These are, of course, things that were brought on by specific events, right? So the first items are distinguished from an Alzheimer's disease in that they are reversible events. Alzheimer's is an irreversible disease currently. And Alzheimer's is a disease that cannot be tracked to one specific event. Alzheimer's doesn't happen suddenly or in response to one event, like a post-surgical procedure or a traumatic brain injury. As was mentioned earlier, pathologies can be associated or causal for a lot of different types of dementia. So I listed a few there: hippocampal sclerosis, Parkinson's disease with dementia, dementia with Lewy bodies. These are all events that have specific pathologies, and by pathology I mean different markers in the brain that we can look at. So structures are smaller than they should be on an MRI. Or when we stain the tissue, we see that there are pathological features there that should not be there in a normal brain or even in an Alzheimer's brain. Oftentimes, too, behavioral issues are associated with different types of dementia that distinguish them from Alzheimer's disease. So whenever we talk about someone's with a Parkinson's disease with dementia, these are people that have a Parkinsonian features associated with their dementia, which is unique and not would not be considered Alzheimer's type dementia, which is non-Parkinsonian. Similarly, people with a Lewy body type dementia will have severe behavioral disturbances that happen coincidingly and sometimes even preceding the dementing part of the illness, which is distinguishable from Alzheimer's disease. The last example is vascular dementia. Vascular dementia has both pathologies associated with it that we can pick up on with an MRI and with a CT scan. We'll talk about those. As well as behaviorally we can see differences, or the progression of the disease is different. And that is that Alzheimer's disease is sort of a slow, continuous, insidious decline, whereas a vascular dementia is one where people will remain stable oftentimes for prolonged periods of time and then have sudden drops in their capabilities and function. And of course, those drops are due to when a vascular event has occurred. Okay, so they have a vascular event, there's changes in the brain function, and then that slowly it stabilizes over time until another vascular event occurs, all right? So when we talk about Alzheimer's disease, we're talking about something that's very specific. It's by far the most common age-related dementia that's out there, and it's distinguished initially from all of these other dementias in many ways. And notice the key thing I'm saying is initially, because once Alzheimer's disease begins to move from mild into the moderate and later stages of the disease, it's sort of a no-holds-bar in terms of what can happen. Okay, there are many different behavioral issues that can happen. There are other pathological events that can occur in later stage disease that cause it to be very difficult to understand what's going on in that individual. So we focus on what initially is causing the dementia. And when we look in Alzheimer's disease, it really is characterized by these features. So it's a slow, progressive disorder. It does not happen suddenly. It is not caused by one thing. Now that does not mean that people can't have beginning stages of Alzheimer's disease that isn't exacerbated by a fall, for example, or a prolonged hospital stay, or a dehydration event. There are certainly things that can exacerbate Alzheimer's disease, but when we talk about it, we're talking about in the absence of all of these other things happening, what does Alzheimer's look like? And it is a slow progressive disorder, significant enough to affect both work and social life. It's primarily a memory disturbance. People are going to retain those abilities to recall things that have happened in the past, okay, at least initially. And then what happens is that the first thing that happens is your ability to lay down those new memories, learn new things, and retain things that are happening in the current time. Orientation is a big problem. Understanding what time of day it is, where were you going, where are you at, all of those sorts of things. And eventually it expands into other areas of the brain, particularly things like executive function, the ability to make a plan and follow it out. And that's one where you see, severe deterioration as the disease progresses. And so these are things that are going to accompany the memory loss, the orientation loss. You're going to start to see more functional declines over time in other areas. And importantly, it happens in the absence of other neurological abnormalities, so balance is maintained, normal reflexes are seen, there's no psychosis, hallucinations, people aren't having those sorts of issues. If they are, then that hints that it's another type of dementia. And you may be saying, why are people so focused on these things? Well, you want to characterize what's causing the dementia as much as you can. Even though we don't have medications to stop Alzheimer's disease or modify the progression of the disease. I just mentioned that there are many other causes for dementia. Some of them are reversible. So that's why it's important to start to diagnose some of these things, to understand what are is it caused by something that can be reversed? Additionally, if people do have a dementing illness that is associated with a lot of these psychoses and issues that are going to lead to severe behavioral disturbances in many cases, you want to know those up front so that they can be managed, each of those issues. And Dr. Demian, I know, will be speaking to a lot of that in the office visit and why the exams sometimes go the way they do. So how is Alzheimer's disease diagnosed? The most important thing that you can walk away from here knowing in this class today is that there is no blood test for Alzheimer's disease. There is no way that we can simply draw blood on someone and say, you have Alzheimer's disease. There are tests that are out there that have been associated with preferentially identifying people in an Alzheimer's group as opposed to non-Alzheimer's groups. But we are far, far and away from having any test that is selective, specific, and sensitive enough to detect Alzheimer's disease. We hope we get there, but we're not there yet. The second thing is, there is no picture of the brain that tells whether or not you have Alzheimer's disease. We cannot take pictures to say, you have it, you don't. Blood tests are used, and we're going to talk about those, and they're very informative to look for things that could be causing dementia, as well as understanding changes that are occurring that are important to manage. And I'm going to talk about that momentarily, as are MRIs, CTs, and PET scans. I'm going to talk about those, what they are, and why people do them. Dr. Keller did not say the blood test and imaging is not important. It is important. But you cannot use any of these to identify the Alzheimer's disease in and of itself, okay? So how do you come up with a diagnosis of Alzheimer's disease? Well, there are many things that are done, that can be done, at the end of class we can talk about whether or not they should be done, but I'm going to list everything that can possibly be done for diagnosis of Alzheimer's disease and why they're done. So a neurological assessment should definitely be a piece of any diagnosis that's occurring. And that's where the physician is going through and looking for those motor disturbances that I was referring to earlier, looking at balance, reflexes, gait, how you walk is a very important feature of that. And as are cognitive assessments, and there's a whole list of cognitive assessments that can be done. Should everybody have a 4-hour battery of cognitive assessments done to them? I would say not. That's not necessary for everybody. Is it important to do in some cases, particularly early stage disease? The answer is yes. Oftentimes those can be helpful in distinguishing subtypes of clinical disorders before the actual disease progresses to a state where it's much more obvious what it is. But there should be some level of cognitive assessments that's done, and it of course should focus on those things that occur earliest. So those things like memory, orientation, executive function. And that's why all of those are a part of that very simple test that's often given, the mini-mental state exam, MMSE. An MRI. So an MRI is magnetic resonance imaging. It is a scanner that people go into. Not everyone can go in and get an MRI. You may hear your doctor say, he can't, she can't get an MRI. Reason why is because there are things like pacemakers and stents and a variety of other implants that can be put into the body, devices that can be put into the body that aren't compatible with that magnetic field that's made by an MRI. Often get that question too. Well, why can't he get an MRI? And that is the reason, oftentimes. And what an MRI does is it's taking very specialized pictures of the brain to allow us to look at the structure. So we can look at things like how big certain areas of the brain are, or the presence of foreign bodies in the brain that are there, or areas where, meaning cancer. Also look for bodies like areas where the brain has had an infarct or a lesion, so where blood has been occluded from an area or blood has permeated the blood-brain barrier into an area. And of course, those things start to lay the groundwork for stroke that we see, or you can have a lot of what we call silent strokes, so and things that go even smaller, very, 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 very minute strokes that can occur in individuals that start to lay the groundwork for things like a vascular dementia. because that's a vascular problem. And you can do things here, like at Pennington and other places, there are studies that are using functional MRI. What that means is that you're actually imaging the brain while specific tasks are going on. I have several of these studies myself, and we do things where you can actually look at memory, have the brain doing tasks that involve memory, and look at the areas of the brain in resting and memory-laden conditions. And they're very sensitive to help to pick up, and probably in the future will be used diagnostically. Right now they're not diagnostic, but in the future they're probably going to be very helpful in coming up with that diagnosis of dementia. And I included a picture here because I think it's always important to, when possible, put like the simplest schematic here, okay, of what's going on. And so what I did here is, this is a section through the brain. So what you're looking at here is an MRI scan, as if the brain is transversed. So as if I'm standing here and the scan is happening right here across my head. My ears would be on either side over here, right? And what you're able to see there, where that little yellow, see the yellow area that's circled there? On the, as I turn around here on the left-hand side, you can see that there is an area that's called the hippocampus, and it's sort of right between your ears here, go in a couple inches. It is critical for learning and memory, and it is structurally supposed to be a certain size, and you can see that on the right-hand side there's a dramatic decrease in that hippocampus. Okay, and so that size is smaller, meaning the hippocampus is very affected in this particular brain. It could very well mean that it's hippocampal sclerosis and not Alzheimer's disease, so I'm not saying this is what Alzheimer's disease looks like, but I'm just giving you an example of how an MRI is used. PET scan, positron emission tomography. So a PET scan, most of you know about a PET scan being used for cancer, where people get radio-labeled glucose injected into their body in areas that are very highly active metabolically, like tumors. Preferentially will accumulate that radioactive glucose so that we can see them. So you can find even very small cancer bodies using a PET scan. And the PET scan in Alzheimer's disease, you can do it a couple of different ways. Some people will use a PET scan with the radio-labeled glucose to look at the level of brain activity, okay? And so that brain activity will light up as being more red, more labeled, being utilized in a given area, as opposed to a yellow to no staining where we see that it's not very metabolically active. Okay, so the idea there is that if we radio label a brain and we see that in the frontal cord, the front part of the brain, that there's a very low level of metabolism going on, very low level of overall activity, and it's just in the frontal cortex and other areas of the brain appear to be fine, that would start to lay the groundwork for something like a frontotemporal dementia being involved as opposed to an Alzheimer's disease. Likewise, if we looked and we saw the hippocampus was not lighting up like we would think that it should, means the hippocampus function isn't what it should be, and again would be sort of consistent with an Alzheimer's, help in that piecing together of this is an area that's involved in Alzheimer's disease, and therefore this diagnosis may be going that way. Another way that PET imaging is used is for radio-labeled ligands, and so there are many ligands that are being developed. The most commonly used now is called amyvid, and what it does is it binds to beta amyloid preferentially. So you can inject this in the body, and 30, 45 minutes later you can look at the brain and it will light up those areas of the brain that have beta amyloid there. And of course beta amyloid is one of the key pathologies that's seen in Alzheimer's disease brain. And so in that case, the higher the intensity of the label, that means the more beta amyloid that is there. And so if you see those deposits and they're at a high level and they're in the right areas of the brain associated with Alzheimer's disease, it helps to build that case that it is Alzheimer's disease. Dr. Keller did not say that PET imaging can be used to diagnose Alzheimer's disease. And you'll have people that say that it can. It cannot. It is part of that puzzle that helps to piece it together. A new one that's coming online is for actual tau pathology, and we may be getting a study for that in the very near future. But people believe that a lot of these, the tangles that we see in Alzheimer's disease with this particular ligand may be helpful in diagnosing Alzheimer's disease and distinguishing it from other disorders that are out there. CT, I did not put that up here, but a CT scan is not like either of these. A CT scan actually shows the blood, and I should have had an example of that, but a CT scan actually helps to look at the vascularization of the brain. And so you can use dye or not use, there's different types of ways that you can visualize these blood vessels. And suffice it to say, you can tell if an area of the brain is having vascular abnormalities or not. And so it's, again, most often used for stroke, if you will, in the context of a dementia. I'll give you one example here of a couple of scans. And so the idea is that, you know, if this was, in this case, it's actually an amyloid scan. So it's an amyloid. It's a ligand that measures the amount of amyloid that's in the brain. And so in this particular, looking at this section of a brain and this section of a brain, you can tell that the one on the bottom has a much higher level of the amyloid in this case. And so there's a much higher burden of amyloid in this individual. If it was, so you would say that this is the pathological brain in this case for an amyloid scan. However, if it was a glucose, if it was using radio-labeled glucose, you would say that actually this scan would be for the normal individual, although there's something going on up here. And this would be the abnormal. So this would be an area where there's not much activity. So the PET scan is used not just to see what if a disease state has less of something. In the case of glucose, it can also be looked to see if they have more of something, for example, amyloid. Okay. Lumbar punctures. Lumbar punctures are used mainly for research purposes. The levels of the different molecules in your CSF, our direct cerebral spinal fluid, are directly related to the concentration of those things in the brain. So we can actually measure things like amyloid and tau in the cerebral spinal fluid and know about how those things look in the brain, whether they're going up or down. And you can also look for evidence of things like blood or infection that also give clues as to what's going on neurologically. And that's why oftentimes a lumbar puncture may be used in a study. And blood, you can use that to measure the levels of thyroid hormone, B12, these other things that are linked to dementia, as well as looking for evidence of infection. And that's always something that needs to be ruled out. So when we talk about Alzheimer's disease too, I mentioned that it is a slow, continual progression. What does that mean? Well, we're talking about in Alzheimer's disease moving from what is quote-unquote normal aging, normal forgetfulness, normal not remembering that face, that name of that face, and going to something else. And so we talk about these things in terms of mild cognitive impairment, mild AD, moderate AD, and then late stage AD. And it's oftentimes these are words that are thrown around, and it's not very helpful to you all because you don't know exactly what that means. And so when I give these talks, I find that it's oftentimes very helpful to give some sort of distinguishing or some sort of markers along this way. Notice that whenever I have this continuum going, I do not have hard lines because it's very hard to demark these things as to where someone is. But in this case, with ADLs, activities of daily living, it is a very clear demarcation. The key factor in moving from mild cognitive impairment to that earliest stage disease is we're starting to see declines in the ability of that individual to do what they once did, so whether it be work or social life. And so this would be the highest level of activities of daily living, okay? Not talking about issues of bathing or dressing and all of those. I'm talking about the very highest level. So your capacity to maintain your work and social life, that is something that starts to deteriorate as we move from mild cognitive impairment to mild Alzheimer's disease. The other thing about mild cognitive impairment is that it's important to go and to get assessments done regularly or at least prior to you suspect having symptoms, because you need to have some sort of baseline with which to refer to. Unfortunately, mild cognitive impairment is one of those things that happens oftentimes in individuals who are still within normal range. By definition, they're not in the dementia range on those standard pencil and paper tests. Okay, so they're scoring outside of what would be normal range, but it's much more sensitive if there's a baseline to compare it to. Okay, does that make sense? Okay. And then of course what happens with disease progression is we move from problems with work to social life to problems in maintaining even basic levels of care for oneself, and therefore you become more dependent and more in need of care to do those things that are involved in daily life. And I think it's also helpful for people to sort of look at these, and I know that Dr. Demian will have his own views on these and to give his opinion on them for his particular clinical setting. And so what I'm doing here is just sort of grouping in my own way some changes that can occur as we move from mild to moderate to late stage disease. And so when we talk about mild to moderate, we're talking, particularly in mild, we're talking about people that are doing less, okay? They're still doing some things, particularly with more and more assistance as you move into moderate. But even at mild stages, these are people that are going to be still doing some things and have some motivations and desire to do certain things that then deteriorates over time and ultimately not only as something that's dropped as an interest, but as something that requires more effort to even have happened, where ultimately in later stage disease they're completely dependent upon others to provide those aspects of daily living. Does that make sense? So oftentimes I tell people sort of Jack and Jane, if you will. So, you know, in mild AD, Jack is one of those people, you know, if you ask, Jack is one of those people who, you know, does Jack still go fishing? Oh yes, but Jack doesn't ever go fishing by himself. He still has some desire to go, and his friends will still take him out to go fishing. Jack still has a garden because the neighbors are assisting with the garden, and Jack still seems to have some enjoyment out of the garden that's there. Moderate stage disease, Jack doesn't have any interest in going out and doing a garden. There's a garden there that the neighbors take. They still have one. Jack's just not interested in it. Late stage disease, oh no, Jack doesn't have a garden. Jack has no interest in a garden. The neighbors aren't helping with gardens, so on and so forth. Jane is, does Jane go and still get her hair done every week at the beauty shop? Mild stage Alzheimer's disease, oh yes. Jane still seems to very much like going to the beauty shop. She's always gone to that beauty shop. I take her, it makes it easier when I take her to the beauty shop. Moderate stage disease, it's very difficult to get Jane to go to the beauty shop. She does not like to go. She doesn't like to leave the house. Jane really likes to stay in the house. And late stage disease, does Jane go to the beauty shop? Oh no. Oh no, we haven't taken Jane to the beauty shop. We don't do that. It's way too difficult. It's very difficult to get her out. Okay, does that sort of help put it in context, sort of those things? And I'll be happy to give more examples at the end of class, but I think it's real important to kind of understand how people are changing and to keep in mind as people are changing their activities and the level of motivation and assistance that they need during, as the disease progresses. So what causes Alzheimer's disease? The way I like to think about this is in terms of things that can be modified and those things that can't be modified. So we have things like age, gender, genotype, okay? These are things we can't modify. So you can't modify who your parents are. You can't modify the extra year that we have. Age is the biggest risk factor by far. I don't want to get into the gender one is actually sort of controversial, but suffice it to say that women have a higher incidence even when you control for age. But age is, of course, women live longer than men, and therefore there is a higher incidence because of that. But even when you control for age, women have a higher incidence. ApoE4 genotype, everybody has ApoE gene. There's genotype 2, 3, and 4. Everybody has 2 copies. If you have a 4, you're at a higher risk for Alzheimer's disease. Bad news is you're at higher risk for cardiovascular disease and stroke and just about everything else that's out there. The good news is you're slightly less susceptible to malaria. Okay? And that's why they think that arose was actually, the APOE4 genotype arose